It's my great pleasure to introduce this morning's Grand Round speaker, Dr. Akshay Desai. Akshay is an associate professor of medicine at Harvard Medical School and the director of the Cardiomyopathy and Heart Failure program at the Brigham and Women's Hospital. He earned his MD degree at Harvard Medical School and then completed residency cardiology fellowship training and then advanced heart disease fellowship training at the Brigham. Following that, he joined the faculty there in the heart failure section. And over the last 2 decades has led many, many efforts to improve the quality of care for patients with heart failure, whether through the development of novel ways to achieve widespread implementation of GDMT or through important work to reduce heart failure readmissions, just to name a few. He's been involved at the highest level in many of the landmark trials in heart failure over the last 20 years and is now the deputy editor of JACC Heart Failure. He's authored more than 250 peer-reviewed manuscripts and was recently named as a highly cited researcher. Akshay is truly an expert in the disease management in heart failure, and we're very excited to have him here this morning to talk to us about heart failure prevention.
So thanks so much, Rashad, and it's really a pleasure to be here and to see many familiar faces in the audience. I'd like to think that even though I've not been here directly, I'm part of the home team, and I was born actually just up the street in the 221 Longwood, which was then the Boston Lying Inn, and actually the neonatologist who delivered me, or was at my delivery, was Bill Cochran, who is a longtime member of the faculty here and actually attended my HMS graduation many years ago. So I feel like I've been connected here for a long time. So I'm truly born and bred in the Longwood medical area, and it's a pleasure to be home. So I'm going to talk today. Let me see if I can make this slides work here. A little bit about heart failure prevention. And while it's not where I've spent the bulk of my time, either clinically or from a research standpoint, I think it's increasingly an area where I'd like to see more focus. And I want to talk to you a little bit about some early work we've done that may be relevant in this space. So we're going to talk a little bit about the way in which heart failure develops and the risk factors that are relevant for heart failure development distinct from development of atherosclerotic cardiovascular disease, where we focus most of our prevention efforts. I want to talk a little bit about established strategies for risk factor modification with an eye to how those strategies might help to delay the onset of heart failure, and talk a little bit about horizon therapies and how they might impact the landscape for heart failure prevention. So it's an ambitious agenda. I'll try to take about 50 minutes and leave time for questions. So it's always useful to set some context, and I think all of you know that heart failure is an increasingly important problem. What you may know less is that the burden is increasing. From the early decades prior to the 90s, we used to say that about 1 in 5 patients is likely to develop heart failure over a lifetime. And partly because of secular trends in the prevalence of risk factors for the development of heart failure and our great success in treating ischemic heart disease such that more patients survive myocardial infarction and cancer therapy, we now have a higher prevalence of heart failure in the living population. It's about 1 in 4, whether you're a man or a woman, with a slightly higher prevalence of HFpEF in women and a slightly higher prevalence of lower LAEF heart failure and ischemic heart disease in men. These trends are such that we project a steady increase in the prevalence of heart failure through 2020, such that there will be roughly 8.5 million cases of prevalent heart failure. This remains the leading discharge diagnosis in elderly patients in the US Medicare age patients, and a great contributor to morbidity and mortality in our populations, and certainly to the bottom line. If you think about what we characterize as heart failure, I think these ACC/HH staging systems are quite useful in highlighting that what we see as heart failure in the hospital, what we'd call symptomatic heart failure, stage C heart failure, or those that we care for with a lot of our resources, and what I do most of the time is advanced heart failure and stage D, is really the tip of the iceberg of heart failure and the patients at risk. So that, and the most recent data, this is from the Heart Failure Stats publication that that is cited, but I think a number of you are co-authors on this publication, highlighting across 3 large epidemiologic cohorts that there is, about a 3% prevalence of symptomatic or advanced heart failure relative to the much higher prevalence of stage A and B disease, that is the population at risk or with structural heart disease that puts people there. And that balances similarly across sex, such that it really doesn't matter whether you're a man or a woman, but your risk is probably high. So I think that this is really the opportunity that we have for more aggressive prevention strategies to prevent the onset or the reactive approach to heart failure management that's characterized most of what we do. So if we think about what it is that actually leads people to develop heart failure, this data from the Cardiovascular Disease Lifetime Risk Pooling Project gives us some insight and highlights that in general, there are three core risk factors for heart failure development. Some of them overlap with the development of ischemic heart disease, but most important perhaps is hypertension. Behind that is obesity and then diabetes. And if we look at these three factors, and lifetime risk for heart failure, those patients who have none of the factors have very low incident prevalence of incident heart failure over a lifetime. And those with multiple risk factors have a much higher prevalence. And this leads the conversation and suggests that if we were more effective in managing core risk factors, these three in particular, we might be able to reduce the burden of heart failure by as much as 75 or 80%. This attributable risk for heart failure breaks down differently across the various risk factors and by ethnicity and race. And you can see that overall, the vast majority of population attributable risk, nearly 40% of that risk, is driven by the prevalence of hypertension. Behind that, obesity, and then behind that, diabetes. And together, those three factors account for about 75 to 80% of the population attributable fraction of risk of incident heart failure. And this varies a little bit by ethnicity, such that in the African-American population, as an example, there's a much higher proportionate contribution of hypertension and obesity to risk than in the Caucasian population, although the same ordering of risk factors is there. And the same is true, really, whether we look at HFpEF or HFrEF over the course of time. And I think this, again, underscores the opportunity that we have in managing simple risk factors, hypertension, obesity, diabetes, in preventing heart failure. So this is what our guidelines say about heart failure, and it's why I think it's important to talk about. There are only 3 Class 1 recommendations in the guidelines that speak to prevention of heart failure. The first is really not much of a recommendation at all. It says we should manage hypertension as we know we should, according to guidelines. The second is that we should consider SGLT2 inhibitors to manage diabetes based on the recent trial evidence. And the last recommendation is a general recommendation based on very little randomized trial data about exercise and lifestyle modification, smoking cessation to reduce heart failure incidence. And so I think what I hope I can convince you is that the field is moved and that there's a lot of advancing opportunity to do more than the guidelines recommend to prevent the onset of heart failure in particular. So I'm going to walk through these 3 core risk factors in sequence and tell you a little bit about how I think the approach might be evolving. First is hypertension, which accounts for that 40 to 50% of population attributable risk for heart failure. We know that hypertension remains a global priority, about 1 billion prevalent cases if we define it at a cut point of 140 millimeters of mercury. And we know that post-sprint, those thresholds have evolved such that actually the number is quite larger. The prevalence of hypertension is rising with secular trends in aging and obesity in the population, and it remains the leading cause for cardiovascular disease and disability-adjusted life years worldwide, a huge proportion of aggregate healthcare expenditure. And if we look at global disability-adjusted life years according to blood pressure, you can see that the large fraction, almost 1/3 of the morbidity, is related to that what we used to consider relatively well-controlled blood pressure of less than 140 millimeters systolic or 90 millimeters diastolic, and that a large proportion of that contribution is cardiovascular disease and chronic kidney disease, with heart failure contributing a large fraction of the associated loss of disability-adjusted life years, and a huge healthcare expenditure estimated at about 100 billion global savings that we could anticipate from better control of blood pressure alone. So this is low-hanging fruit for the clinic, but still I'd argue that we are a little lackadaisical in our approach to management of simple risk factors. So you're all familiar with the data from the SPRINT trial, which suggests that strategies of more intensive blood pressure control, even when we're comparing to relatively familiar targets of less than 140/90 versus a more intensive target of 120, is associated with meaningful reductions in overall mortality, as well as the incidence of heart failure. And this has really driven changes in guideline recommendations as to what constitutes an optimally controlled blood pressure, such that we're striving for blood pressures less than 130/80, and perhaps even as low as 120 in the vast majority of our population. But when we look at the prevalence of treatment and control of hypertension in the population, those rates remain relatively low, embarrassingly low, right? About 40% of patients are actually treated. And of those who are treated, only about 1 in 5 are actually controlled to guideline recommended targets. And that means that there's substantial residual risk that is an opportunity for prevention of both ischemic heart disease and incident heart failure. So why don't we do a better job with treatment of hypertension? I think there are a number of reasons. One is access to care, and I think there's been a lot of discussion of this. If you don't see a physician or a nurse or an advanced practice provider, then you're probably not going to have your hypertension recognized. I think that in general, on the patient side, we could do a lot more to make awareness of the importance of hypertension. And I think the barbershop study that was published some years ago was a very interesting example of how we can enhance community-based awareness of hypertension and improve treatment and control. I think we don't make a diagnosis. If you look at our encounters in EPIC, when I see patients in clinic, and you look back at the many opportunities that patients had to encounter the system, either virtual or in person, the vast majority of time, there's no blood pressure associated with that encounter, which means that we've had several contacts with the patient where we've missed an opportunity to do something simple to improve clinical outcomes. I think we're also a little prone to kicking the can down the road in clinic. For the most part, we see patients and then don't make changes in therapy because that's a lot easier than it is to initiate a therapy, check a lab and follow up, and then follow up with the patient. And then on the patient side, I think that when we prescribe medicines, either because of cost issues or because of adverse effects or because of just the burden of pills that we're prescribing to patients, patients don't take the medications. And then about 10% of patients with hypertension are resistant, and even with 3 or 4 medicines on board, continue to have uncontrolled blood pressure. So here's where the new information comes. So the question is, what's out there that might make this better? So one option is just more medications, and we certainly have a number of new medications that are coming down the pike for management of hypertension. This is the new pharmacology of hypertension that you'll expect to see. The question is really whether any of these will move the needle over established therapies, particularly use of spironolactone for resistant hypertension. But there are therapies, including nonsteroidal MRAs, aminopeptidase A inhibitors that inhibit generation of angiotensin III, dual endothelin receptor antagonists, which may skirt some of the edema and volume overload issues that confronted patients with ETA receptor antagonists, aldosterone synthase inhibitors, which may offer some incremental advantage in hyperaldo states. There are also subcutaneous therapeutics or parenteral therapeutics, including ANP analogs like MANP and angiotensinogen inhibition, which is targeting RNA for angiotensinogen, which we'll come back to. And then device-based therapies, including renal denervation and carotid baroreceptor stimulation, some of which I know you've had a role in development of here. So I'm going to focus on 2 of these, which I think are either more mature in their development or where there is, I think, opportunity to address some of the barriers in hypertension treatment that we've talked about in practice, particularly the issues with adherence and therapeutic inertia. So we'll start with renal denervation, and I'm going to do this quickly and perhaps not do it justice for those of you who live in this space, but I think it's important to acknowledge that there has been a wealth of information about the opportunity for renal denervation as a therapy for patients with hypertension. The most recent large phase 3 randomized controlled trial data was from Simplicity-3. And in that trial, you'll remember that at 6 months, there was no statistical difference between sham and this approach to ablation with regard to control of office or ambulatory blood pressure at the 6-month interval. However, when you looked at extended follow-up of the trial, including imputation for the patients who crossed over to renal denervation, which was about 30% of that population, you can see that there were at 12, 24, 36, and even out to 5 years, increasing reductions in blood pressure that were seen in the intervention group compared to the sham control group. And even if you mute some of the placebo effect that was seen in this trial, which was the rise in blood pressure that happened in the sham control group or in those who didn't cross over, there's still a signal of pretty substantial blood pressure reductions in this resistant hypertension population. Now, there were a lot of problems with this trial about operator experience and the approach to ablation that was used, the completeness, the success rates, but it was safe, seemed to be effective. And then we have subsequent trials that are additionally sham controlled of the same therapy, now improved in terms of its circumferential ablation in the renal artery. And you can now start to see smaller but more reliable reductions even at 3 months in both ambulatory and office-based blood pressure. with this approach, and then ultrasound-based approaches that may be even easier to use, which in meta-analysis seem to be associated with meaningful reductions at 6 months in both daytime, nighttime, office, and ambulatory blood pressure. So I think this cements the data set, which suggests that renal denervation may offer a modest incremental advantage over oral therapy with regard to blood pressure reduction. That effect seems to be consistent across the techniques that are used, whether ultrasound or radiofrequency ablation based, whether you're looking at early generation or late generation, whether you're looking at patients treated or untreated with hypertension. And so I think this becomes another therapy in the arsenal for management of those with hypertension. And with both therapies, the ReCore device and also the Medtronic device are now approved by FDA as of late 2023. I think the big question that's open is really, who should get this therapy and where it makes sense to deploy. I think we can all imagine the therapy being deployed in those whose hypertension is resistant to standard therapy, but I'm not sure that the patient who just is not inclined to take therapy is such a great patient in which to commit to an invasive procedure, but maybe that's where the field moves. So I think there's more to talk about here. And then I think this is a nice foil then to talk about other strategies, which are novel pharmacologic strategies. And I'm going to spend a moment, partly because we've spent some time thinking about this, on novel approaches to renin-angiotensin system inhibition, including RNA-targeted therapies, because I think this is sort of an interesting paradigm that's been applied in lipid management that may have legs in hypertension management, and I'm going to try to persuade you of that. So we all are familiar with renin-angiotensin system inhibition as a strategy both for hypertension management and for heart failure management, and there are multiple points along the pathway where we have effective therapies, including familiar drugs like ACE inhibitors and ARBs, and then more proximate inhibition with renin and with plasma renin inhibitors. I think all of these share the physiology that when you inhibit the angiotensin system, there is a rebound feedback loop that leads to rise in renin secretion that over time may lead to escape of angiotensin system activation that overwhelms the inhibitory therapies and also contributes to ongoing risk for adverse effects, including hypertension and worsening renal function. What hasn't been available until recently is opportunity to inhibit the substrate generation step for renin, which is blockade of angiotensinogen generation. And if you can deplete that substrate by depleting the message for production of angiotensinogen with either small inhibitory RNAs or small interfering RNAs or antisense oligonucleotides, then all of a sudden that rebound rise in renin secretion becomes less important because there is no substrate for renin to cleave. So why do you target angiotensinogen? Well, it's the sole precursor to angiotensin peptides. We have a lot of epidemiologic data from genetics that suggests that variants in the AGT gene are associated with risk for incident hypertension over time. Levels of circulating angiotensinogen correlate with the severity of hypertension in patients who have elevated blood pressure. And if we look at preclinical models that overexpress angiotensinogen, we know that they are associated with the phenotype of hypertension, endothelial dysfunction, ventricular hypertrophy, renal dysfunction. And so it recapitulates the clinical syndrome. And so there's a lot to believe that if we could suppress angiotensinogen, we might actually modulate both the incidence and severity of hypertension. So what are the approaches we have? Well, there are two available RNA-targeted approaches. Now, you're familiar with some of these from the lipid experience, but just to remind you, small interfering RNAs are essentially double-stranded RNA preparations that are conjugated to an N-acetylgalactosamine ligand that is endocytosed through the acyl glycoprotein receptor in the liver. Once that happens within the endosome, there is cleavage of the siRNA into a guide strand and a passenger strand. The guide strand then binds a RISC complex that allows for binding to the target message RNA strand that then targets that mRNA for degradation. There's also a single-stranded DNA-based approach with an antisense oligonucleotide that is complementary to the target mRNA strand, endocytosed through a similar mechanism when conjugated to the same ligand that again targets the mRNA for degradation. And we have examples of both of these that are available for targeting angiotensinogen that are branded, and I've given you the names on the slide. So why conjugate the peptides to N-acetylgalactosamine? Well, this allows for targeted delivery to the liver, which has some advantages in this class. Because the acyl glycoprotein receptor is unique to the hepatocytes, The targeting of the drug is now liver specific, and there's limited effect then on the pool of extrahepatic angiotensinogen expression. And in theory, then limited off-target effect for tissue-based RAS systems in the kidney, for example, and more targeted effect in the liver. And this may offer the opportunity for suppression of circulating angiotensinogen and its downstream consequences with limited off-target effects in the kidney, where a lot of the limitations of therapy occur. The other advantage of this approach is that because these compounds are engineered for stability at low pH within the endosome, they have a very long half-life. And so particularly the siRNA-based approaches are drugs that hang around within the hepatocyte for several weeks or even months, which allows for a prolonged duration of action. Now, that's great in lipid therapy. It might be great in hypertension, but it might have some disadvantages, and we can come back to that as well. But I want to walk through a little bit of the data we have about use of these compounds to treat hypertension, just to pose a counterpoint to what you well know from the renal denervation literature. And I'd like to make the point that I think these are potential opportunities to replicate some of what you could do with renal denervation with now a subcutaneous compound. So here's the ASO targeting AGT, the Ionis compound. There are 2 small trials of monotherapy and then add-on therapy that have been conducted. Total N here is about 50 patients. So these are short duration, small randomized controlled trials that are largely about proof of concept. And so if we look at the data from these trials, what we can see in blue is the effect of the AGT ASO versus placebo in patients with moderate hypertension. Y-axis here is the level of angiotensinogen, and you can see that there is a rapid onset of angiotensinogen suppression within weeks of administration of the compound that then recovers by about a month to baseline levels. And then you can see that reduction in angiotensinogen parallels reductions in blood pressure, such that the concept is proved. If you get angiotensinogen suppression, you get fairly effective blood pressure reduction. There are ongoing trials of this approach that are larger in patients with resistant hypertension or HFrEF. The thing to know about the ASOs is that they're generally administered on about a weekly basis because the effect tends to recover within a week or so of dose administration. And you'll contrast that with the approach of using an siRNA, and the commercially available agent, not the commercially available, the agent that is available is zilebesiran. Zilebesiran is an siRNA targeting angiotensinogen, and this data that we published earlier last year looks at dose-dependent effects of zilebesiran in a mild to moderate hypertension population. And you can see that compared to placebo in red, that there is a dose-dependent reduction in circulating angiotensinogen after a single dose of zilebesiran administered at time 0 here that endures to 12 weeks and to 24 weeks. So that's pretty impressive, right? Because it means that by week 3 after administration of the drug, there's a 90% reduction in the circulating levels of serum angiotensinogen with any dose greater than 100 milligrams. And then by 24 weeks with the highest dose, there's a sustained effect, more than 90% suppression of angiotensinogen, again, from a single dose. So that reduction in angiotensinogen is associated with meaningful reductions in blood pressure. And here is the dose-dependent reduction at week 8, week 12, and week 24 in systolic and diastolic pressure. This is ambulatory blood pressure. I could show you the same for office-based blood pressure. These are meaningful reductions of upwards of 15 to 20 millimeters of mercury in systolic blood pressure that are sustained from 6 months from a single dose. You might ask, well, that may not be so good, because if you've got a patient who becomes hypotensive for a reason, they develop bleeding or sepsis, or maybe they take an extra medication, how do you rescue blood pressure? We have some preliminary evidence, and this is all phase 1 data, that there is some modulation of the system, as there is with all RAS active agents with salt, dietary salt intake. And if you look at the effects of low versus high salt intake on the effect of zilebesiran in patients with mild to moderate hypertension, you can see that under low salt conditions, blood pressure falls in both groups and returns with high dose. And then you give zilebesiran, the effect of a low salt diet is accentuated in the presence of zilebesiran. But when you give a high salt diet, blood pressure again recovers even on the zilebesiran treated patients to baseline. These are very high salt diets, about 6 grams of sodium a day, well more than most of you eat, I hope. But if it at least makes the concept that you can rescue the effect with high sodium diet. The preclinical data also suggests the effect can be rescued with conventional pressors, vasoconstrictors, at least in preclinical mouse models. And so there is the belief, at least, that this agent can be reversed with conventional strategies that are not reactive within the RAS. The other issue is that there are targeted reversor agents that are under development that would allow for a focused reversal of the effect in patients who develop severe hypotension. So there's a rescue strategy that is underway. So the other issue with this approach is that we struggle a bit with oral hypertensives because of the variation in peak and trough levels over the day and the variability in blood pressure that ensues. And also because patients are inconsistent in their adherence with medication, there's a lot of variability visit to visit in blood pressure. And we know from the hypertension literature that that inconsistency, that visit to visit or intra-visit variability contributes further to the risk associated with hypertension. So lability is not a good thing, particularly if it happens over the diurnal cycle. And we know now that these agents, much like renal denervation, provide consistent blood pressure over 24 hours, both day and nighttime blood pressure equivalently reduced. And that persistent reduction over the full 24-hour interval may be an advantage of these compounds when we think about CV risk reduction. There is now more data from larger experiences. Cardio-1 was presented at the American Heart Association in the fall. This is, again, a dose-ranging experiment in a randomized fashion of patients with mild to moderate hypertension, simply scaling the experience that we had from the phase 1 experience. And the message is very much the same, that at doses exceeding here about 150 milligrams q 6 months, there seems to be a dose-dependent reduction in both the angiotensinogen message and in blood pressure. The tolerability was excellent in this population. Only one episode of symptomatic hypotension that required intervention that was responsive to saline infusion, and the rest were mild, moderate, or transient. No severe episodes of hyperkalemia. Those that did occur were mild to moderate and often reversed on repeat check without intervention. So I think that this, again, the 24-hour interval is consistent, and I think you get the message that this is an effective therapy in a mild to moderate hypertension population, single doses that have an enduring effect through 3 to 6 months after dose administration. So there's more data coming. You'll see at the ACC some data from Cardio-2, which is an add-on therapy experiment with a larger population to provide additional agent about how these drugs might work in combination, and then a resistant hypertension trial that should follow in the fall. So a lot more data to come to prove the safety and then potential application of this strategy in hypertension. So I'll shift gears now in the next few minutes to talk a bit about diabetes and then obesity, and then we'll close. And I think this population knows, this team knows a lot about management of diabetes, but I think when we think about diabetes, we generally think about 3-point MACE and CV death, MI, and stroke, and we rarely think about heart failure. But I think you should remember that heart failure contributes to a substantial burden of the morbidity in patients with diabetes. And if you look at a diabetic hypertensive population, like in the LIFE trial, you can see that regardless of treatment arm, there is a moderate incidence of incident heart failure over time. And that risk is only amplified when you add chronic kidney disease to the mix, and as was done in the diabetic nephropathy trials. And then we know that if you look at trials of diabetic nephropathy in particular, like this trial of a plasma renin inhibitor that we led, you'll see that the incidence of atherosclerotic events is real, but it's actually dwarfed by the incidence of heart failure in these trials. And actually the aggregate morbidity associated with MI, stroke, and end-stage renal disease is less than that associated with incident heart failure in some of these trials. So prevention of heart failure is really a core strategy in patients with diabetes, and so we need to think about how to do that. What's interesting about diabetes is that unlike atherosclerotic cardiovascular disease, these outcomes are not heart failure outcomes are not well modulated with control of standard risk factors to guideline recommended targets. So this is data from the Swedish National Diabetes Register looking at 5 core risk factors or biomarkers of risk. And if you looked at incident MI and stroke, with control of all 5 of these risk factors, you can essentially restore risk in a diabetes patient to baseline. But with regard to heart failure, particularly in younger patients, even if you control all these risk factors, there's still a lot of residual risk for incident heart failure that is unattended. And this is the opportunity for targeted therapy in diabetes to specifically modulate heart failure outcomes. So you know that intensive glycemic control is relevant for modulation of microvascular outcomes in diabetes. It has modest effects, if any, on macrovascular outcomes, particularly heart failure. And so these strategies of intensive A1C targeted therapy with insulin and other strategies are not as effective in heart failure prevention, and there might be some signals of increased risks with those strategies depending on the one you select. We also know that thiazolidinediones, as an example, may worsen risk for volume overload and heart failure, and it's really this observation that drove the FDA to guide new diabetes therapies through a different process for approval, which required trials that were randomized and adequately powered to demonstrate safety, because it was clear as of 2008 that not all drugs that treat diabetes have the same impact on long-term cardiovascular outcomes. And since 2008, we have an explosion of large randomized controlled trials in diabetes that have given us real information about how the therapies differ with regard to their risk of incident cardiovascular disease and heart failure in particular. DPP-4 inhibitors are some of the most widely prescribed drugs for treatment of diabetes, but they do almost nothing to modulate cardiovascular risk. The CV death, MI, stroke are entirely the same regardless of the agents you choose. And the same is true of heart failure hospitalization, which in the saxagliptin trials was actually worse in the patients assigned to saxagliptin. And yet, because these drugs are so easy to use, you prescribe them, patients never call back, you don't have to check a lab, they're still some of the most widely prescribed drugs for treatment of diabetes in the arsenal. What does matter are other agents that you now know well, including GLP-1 receptor agonists and SGLT2 inhibitors. And I want to look at these agents from the lens of a heart failure prevention strategy and remind you that there are a lot of systemic effects of GLP-1 receptor agonists that might be beneficial in a patient population at risk for heart failure. The first is that they reduce weight, and we have a lot of data about weight loss that we'll come back to. There's an impact on blood pressure. There's certainly an impact on circulating glucose. There's reduction in hepatic fat and non-alcoholic steatohepatitis, and then there's reduction in albuminuria that may lead to some renal protection. A lot of reasons to think that in a primordial prevention strategy that these drugs may have benefit in modulating the risk of incident heart failure in addition to atherosclerotic disease. What's interesting from the diabetes trials, though, is that we see a tremendous reduction and consistent reduction, regardless of therapy, in major adverse cardiovascular events, CV death, MI, stroke, over the duration of follow-up that was contained in these trials, regardless really of the agent we use. But when we look at heart failure events, there's less of a signal of benefit, at least at the doses studied in the diabetes trials. There's really a modest effect, if any, in aggregate of GLP-1 receptor agonists on heart failure outcomes. And so it seems to be the case, at least in diabetes, that at the doses we conventionally use to treat diabetes, that the effect of GLP-1 receptor agonists in an unselected diabetes population is principally on CV death, MI, and stroke, less so on incident heart failure. And that contrasts, as you know, with the effect of SGLT2 inhibitors in patients with heart failure. And this is the pivotal data from EMPA-REG OUTCOME, the empagliflozin trial in patients with type 2 diabetes at high cardiovascular risk. This was groundbreaking, 38% reduction in overall CV mortality, a modest reduction as well in overall mortality in that trial. Much of it driven by the effect on incident heart failure, which really has girded the rationale for doing dedicated trials in heart failure, for which you all know the results and implications. So here's the data for SGLT2 inhibitors, and the story is a little inverted compared to the GLP-1 receptor agonist story in diabetes, that in general, with regard to major adverse cardiovascular events, although the numbers come down, they come down a lot less than with GLP-1 receptor antagonists. And the big effect seems to be the effect on modulating incident heart failure outcomes. And this is effect across the class, whether it's DAPA, CANA, EMPA, and maybe even Bexa and ertugliflozin. So I think there is now a consistent message that these drugs are useful in prevention of heart failure, which is why they get the nod in the guidelines for prevention. And SGLT2 inhibitors are relevant. What we don't have really is that data in non-diabetic populations about the opportunity for SGLT2 inhibitors to prevent heart failure incidents. And I think really which patients who don't have diabetes might be candidates, is sort of an open question. I think what we do have some data about primary prevention in non-diabetes is in the kidney disease population. And I would just remind you that there's now an auxiliary indication for use of SGLT2 inhibitors in patients with chronic kidney disease based on the data from this trial, DAPA-CKD, that suggested a marked reduction in the incidence of renal disease progression in patients with CKD and proteinuria who were randomized to therapy with dapagliflozin or placebo, comparable data from EMPA-KIDNEY with empagliflozin. But I think unique to the DAPA-CKD population is this a signal on heart failure prevention, which was reduced quite dramatically in a CKD population, and the effect is entirely consistent in those with and without diabetes. So now, not only is the drug class relevant for heart failure prevention in a diabetic state, but also for those patients with chronic kidney disease with or without diabetes. And we've already mentioned that CKD prevention or prevention of that progression is another way to modulate long-term risks of heart failure development. So what else do we have? We also have now novel data about MRAs in this population. We've long been interested in MRAs for prevention of CKD progression, particularly in diabetic nephropathy, because we know that activation of the mineralocorticoid receptor potentiates a lot of the disease processes that are involved in progression of both heart and kidney outcomes in this population. The activation of the mineralocorticoid receptor is associated with enhanced oxidative stress, activation of a number of pro-inflammatory pathways, worsening of tubulointerstitial fibrosis, mislocalization of sodium ATPase in the distal tubule, alterations within the glomerulus, myriad effects that result in renal disease progression, and then similar effects on fibrosis and inflammatory pathway activation within the heart that contribute to the incidence of heart failure. And so we know that in established heart failure, MRAs have a lot of value. There is the belief in advanced kidney disease, particularly as it relates to diabetes, that they may also modulate risk of incident heart failure and other CV outcomes. The problem, of course, is that in those populations that are at high risk for renal disease progression and hyperkalemia, they're hard to use, and there's a high risk of administration of spironolactone and eplerenone and a reluctance to deploy these agents. So enter nonsteroidal mineralocorticoid receptor antagonists, which we mentioned are being explored as a therapy for hypertension. And we now have across 2 trials, Fidelio and Figaro. This is the pooled Fidelity meta-analysis synthesizing that data. The use of finerenone is associated with substantial reduction, not only in progression of kidney disease in a diabetic kidney disease population, but also in the incidence of cardiovascular endpoints, including death, MI, stroke, and heart failure as a composite. This is a meaningful reduction over just 4 years of follow-up in incident heart failure and CV disease. And most of that signal, if you look at the components of the composite endpoint, is heart failure. So now proof of concept that you can deliver an MRA, a nonsteroidal MRA in a diabetic kidney disease population, prevent heart failure with substantial effect, with a limited risk of hyperkalemia, perhaps less so than we've seen with some of the conventional steroidal mineralocorticoid receptor antagonists. And this effect seems to be layered on the effect of SGLT2 inhibitors in this population. So we now have further explorations of this approach, not only as a strategy for heart failure prevention, but also an established disease. We're completing the Fine Arts trial, which is now fully enrolled and approaching the end of follow-up, which is a trial of nonsteroidal MRA therapy in patients with heart failure and ejection fraction more than 40%, and that data we hope will report out later this year. I'm going to finally close with a note on obesity. I think it's well established that obesity is a predictor of worsening heart failure. I've shown you that data early on. And over time, obese patients and even those who are overweight by the current definitions are at higher risk for heart failure incidence over the lifetime. And there are many strategies for modulating that heart failure risk, including physical activity and lifestyle modification for weight reduction, which does have a modest effect based on epidemiologic data on heart failure prevention. And then this data about surgical weight loss and reduction. And here's the observational data set from the Swedish obesity study that suggests that targeted weight loss with bariatric surgery might be associated with modulation of risk for incident heart failure, marked reductions in weight, as you know, with sleeve gastrectomy or gastric bypass surgery with Roux-en-Y. And that reduction in weight correlates with a marked reduction in incident risk for heart failure over a long duration of follow-up. This is 22-year follow-up in the Swedish obesity study. Quite impressive. You can see a pretty substantial reduction in risk of nearly 35% in incident heart failure. So powerful data that reduction in weight, through this strategy at least, seems to be associated with improvement in heart failure outcomes. It seems to matter how you reduce weight, that not all weight loss is good in patients who are at risk for heart failure. If you lose lean body mass rather than fat mass, there does seem to be a difference in the risk for heart failure development. Most of the benefit seems to come from at least 10% loss in fat mass, which seems to reduce the incidence of both HFpEF and HFrEF. If most of the weight loss is in lean body mass, which is the way we characterize cachexia, the signals of benefit may be attenuated. So we're trying to figure out how else we might modulate reduction in fat mass. And then we know now from the SELECT trial, which was published just late last year, that in 17,000 patients with obesity, established cardiovascular disease, and no diabetes, that we can, with semaglutide 2.4 milligrams once weekly, affect tremendous changes in weight and waist circumference. So we've now reduced not only overall body mass, but also central adiposity. And with reduction in central adiposity and total body mass, there's a parallel reduction in incident cardiovascular outcomes. Here, the signal is not only for CV death, MI, and stroke, which is 3-point major adverse cardiovascular events, but also seen in incident heart failure, which is reduced by 18% over the course of the trial. Again, proof positive that targeted strategies for weight reduction, particularly central adiposity reduction, can modulate the risk of incident heart failure. So I'm going to close now with a couple of notes about how we might deploy this in practice. And I think Rashad was kind to reference some of the work that we've done in implementation of strategies for heart failure management. And I want to show you that some of these, at least at a healthcare system level, can be deployed at scale to also manage population level risk for heart failure, hypertension, diabetes, and obesity. Here's the proof of concept. This is data that was presented just last year, looking at a remote optimization program for hypertension using navigators and pharmacists. This is a program that was essentially driven by proactive engagement of populations that were identified from the electronic health record as having uncontrolled blood pressure or lipids. There was then a reach out to those providers to get permission to approach the patients, and then a partnered outreach to patients saying that we're here to help manage your blood pressure and diabetes. Patients were sent a remote cuff, were connected with local labs, and then followed for a period of time with deployment of structured interventions to manage hypertension and lipids according to a predefined algorithm that was run entirely by pharmacists under a collaborative drug therapy management program. And what you can see is that over time in this essentially observational study, that there's a steady reduction in blood pressure, steady reduction in LDL to guideline recommended targets. This is one healthcare system of about 3,000 patients, but you can see at least the opportunity for this to be implemented at larger scale. And we are now developing this as a strategy now that it has expanded reach in patients with diabetes, where we're now using a similar algorithm-based strategy to deploy SGLT2 inhibitors and GLP-1 receptor agonists. This takes out of the provider's hands the need to manage the prior authorizations, to fight the battles with insurance, because all of that is handled within the program. And this is a proactive outreach strategy, which then circumvents the tendency we have in clinic to kick the can down the road and make it someone else's problem, right? The same strategy has been led by Carolyn Apovian and her team in the weight management center at the Brigham and Women's Hospital for obesity. There are EHR-based prompts to engage clinicians to connect patients with online management strategies for weight loss, including this one from Restore Health as an example, where they can get online coaching through an app for weight reduction. And then those patients who have struggles with weight gain or fail to lose weight in that strategy are then connected with more targeted management strategies within the weight loss clinic. So a scaled strategy, low-hanging fruit for everyone, and then a more intensive therapy for those who fall through the cracks. And so I think these are the types of implementation strategies which will be necessary. Take the physician or the advanced practice provider out of the loop and move the system from one that is reactive, largely based on treating the problem in front of you, to one that is proactive, identifying the patients at risk, reaching out, and aggressively managing. And I think that's the way you move the needle at scale to prevent heart failure and other cardiovascular disease. So with that, I'll close and say that I think hypertension, diabetes, and obesity are familiar, but important risk factors for heart failure development. We don't do a great job in managing any of them, and hypertension in particular, which drives most of the population attributable risk fraction for heart failure, is very poorly recognized, treated, and controlled to targets. There are novel strategies that are now part of the arsenal with renal denervation and perhaps RNA-targeted therapies that may offer strategies for tonic inhibition of blood pressure that doesn't rely on day-to-day adherence to a pill that the patient may elect not to take. We know that we can modulate risk for heart failure in patients with diabetes and in those with CKD using SGLT2 inhibitors. And we know that in patients with diabetes and kidney disease, there may be an opportunity for nonsteroidal mineralocorticoid receptor antagonists. The story with GLP-1 receptor agonists is the modern story, which highlights that we can reduce weight now with targeted pharmacologic therapy that can modulate, importantly, the risk of both incident MACE and incident heart failure. And I think there are novel strategies for population health management that I think are now really the substance of what will be a whole nother generation of clinical trials to come about how it is that we target population level health improvements, particularly as we move to value-based payment models where this will become even more important. So with that, I'll close and thank you for your attention and take any questions you might have. Please.
Willing to so involved with this bit of ambiguity. How do they do it? Like, how are the drugs working? And there was this recent article that came out that talked about that it's regardless of its diuretic effect, that there's clearly some sort of anti-inflammatory effect of the heart and the kidney, and talked about how possibly there's relative starvation from the glycosuria is leading to less transit through the central phosphate pathway, and how uric acid levels can be a marker of this. I mean, is that how we're thinking about it? I mean, it seems to be a window into how to attack prevention of heart failure and kidney disease in the future.
Sure. So I think the question largely speaks to what mechanisms of SGLT2 inhibitor effect are actually contributing, I think, to the incidence, to the benefits that we see in clinical practice, both in prevention and in established disease. And I think it is $1 million question, maybe even more than that. I think that some of the effect. I think it's easier to say maybe what we don't think it is. I don't think it's entirely a diuretic effect. I think there is a diuretic effect of these drugs, but they're more than smart diuretics. We have a lot of proximal tubule active diuretics that don't seem to have the same effects on clinical outcomes over the long term. And the effects on volume depletion are fairly low and they're fairly early. There's not a long-term effect there that would be expected. So it has to be an effect either on the kidney or an effect on metabolism in general. I think there are a lot of different theories. You've forwarded some of them about what may be relevant, including substrate utilization focused theories that focus on autophagy, which has been advanced, and its impacts on sort of the clearance systems for debris within the cells. I think also some effects that may be direct myocardial effects of these drugs. I think which of those dominate in practice, particularly in a prevention model, are a little bit hard for me to understand, but it's clearly not about glucose control, and it's clearly not purely about volume depletion. Please. Yeah, I think a critically important question. And I'm sad to say that I think we're pretty far from that at this point. I think that the state of the art, I think, is largely what I've shown you, which is that we know that there are some patients some core risk factors which are associated with risk for heart failure development, and they overlap with those for ischemic heart disease development, that those patients who accumulate more of those factors are at higher risk. And so I think the best marker of highest risk is really identifying those patients who have the largest pool of accumulated risk factors and targeting those patients. I think there may be some incremental advantage with some early biomarker screening, and I think Jen Ho and others here have highlighted that if you utilize natriuretic peptides as an example in a screening mode, that you might reclassify a large proportion of populations that you wouldn't recognize to be at risk as being at higher risk for incident heart failure. And so if you take the older approach to staging heart failure, stage A, B, C, and D, and then layer on natriuretic peptides, you'll move a large number of people from stage A to B as having sort of established structural heart disease that you may not have recognized with other approaches. So I think that is one approach. I think the holy grail here would be better and more discrete phenotyping of populations, both at risk for heart failure and with established heart failure. I know there's a lot of work being done on the higher EF populations to begin to segment the population a little better and then look back at where they came from. One of those strategies that we're participating in is the HeartShare initiative, which is shared effort across 7 national centers to recruit a cohort of 1,000 patients with HFpEF and then thoroughly characterize that population with deep phenotyping that might include imaging, biomarkers, genetics, and other things, and then hopefully segment the population a little better, and then potentially look back at how those patients got there and identify novel risks. So we hope out of some of those late phase projects, taking the patients who've committed and developed heart failure, we can begin to unpack who they were before and what factors might drive risk in a way that will then inform some of that more targeted phenotyping and drug delivery that you're talking about.
Great talk. There's one large pharma company in particular that's beginning to modulate not just GLP, but GIP as well. It's combination therapy. In fact, I read that their stock has almost doubled in the course of the last year. And, I wondered if first, okay, but more importantly, are there any reasons why GIP, gastric inhibitory peptide, might add some value?
Yeah, I think it's a little early to know. I will say that what we are impressed by with the dual agonists is the incremental weight loss that one seems to get, and I think that will pay some dividends with regard to some of these. Whether there's a specific effect that exceeds weight loss, that's been really hard to unpack, even with the semaglutide story in SELECT and in the more recent trial in the HFpEF population, which was called STEP-HFpEF, that was a non-diabetic population with heart failure, higher ejection fraction, randomized to semaglutide 2.4 per week or placebo. What you saw was a marked reduction in weight and a marked improvement in functional capacity measured by KCCQ. There was a lot of debate after that trial was released as how much is weight reduction and how much is a myocardial effect of GLP-1s. And I don't think we know, but there is a marked BNP reduction in that population that seems to exceed that you would expect from weight loss alone. So there is some effect of GLP-1 on the heart. Whether the same is true of GIP, I don't know. And then there are triple agonists that are coming down the pike, which will offer sort of other strategies for modulation. So the tirzepatide story is very interesting. I think it will we'll have some data from Summit, which is a HFpEF population that should come out in another year or so. And then I think the Cleveland Clinic and Steve Nissen are running a broader trial of obesity reduction that's comparable to SELECT with tirzepatide that should report out in another couple of years. So I think we'll have some more data, but I don't have a lot of insight into the specific effects of GIP on incident heart failure.
What's the mechanism of heart failure with obesity?
Yeah, I think some of it is difficult to dissect out from the associated risk of obesity on hypertension, on sleep apnea, on pulmonary hypertension, RV function. I think that some of it also may be related to the effects of obesity on incident diabetes and insulin resistance, and that clearly is associated with effects on incident heart failure. And then some of it may be just a mechanical effect of pericardial constraint, right? So we know that obesity is associated with not just central adiposity, but also epicardial fat, and epicardial fat has its own impacts on pericardial constraint and filling, and then may also modulate risks for local inflammation and risk of heart disease. We know it's associated with incident atrial fibrillation as an example. So I think maybe multiple mechanisms, and then some I haven't mentioned, don't know about.
Thank you, Dr. Such. Super interesting. We're engaged in the small most striking is that striking trend is that
Mm-hmm.
which then takes you to the next logical conclusion, which is that GLP-1s are probably the shortest term savior of that. When you think about GLP-1 and heart failure, and you should some of the data, is the mechanism primarily through fat reduction or fat population?
Yeah, so I think it's likely to be mostly HFpEF reduction, because if you look at the epidemiology of heart failure in patients with obesity, it's not entirely, but it is largely HFpEF. But I think there is reason to believe that if some of these mechanisms operate in patients who go through the HFrEF pathway, that there should be some impact on HFrEF development as well. I think all the focus has been in the higher EF populations because that is the more familiar phenotype that we see. You know, with regard to this, to being the savior of that epidemic, I hope you're right. I think we've struggled a lot with cost, with access and supply. And that's why I think more entrants into this field are pretty important, because I think as we have a proliferation of newer options, the patent life is still relatively long on those drugs compared to some of the others. So I think it's a while before we see competitive generics. So I think we need more entrants to drive the price down. And then I think we have to also remember that it's not the only approach, right? And I think we have to get a little bit more aggressive about engaging with patients early in life, childhood obesity prevention, management. And then later in life, I think we need to stop viewing surgical weight reduction approaches as last-ditch opportunities. And I think for some patients, the technology has improved, the morbidity has been reduced to a point where it's a much more reasonable conversation, even with patients who are not severely obese, of the type that we're commonly referring for those options. But yeah, I hope the drugs will transform that. It's just a question of whether we can get them to the right patients. Oh, sure. Yeah. So it's funny, I threw the renal denervation story in late to this talk because I kind of felt like it's something one has to confront. It's an approved therapy. My personal opinion is that the effects of renal denervation, at least as they've been seen in the trials, are fairly modest. I think over and above effective medical therapy, and one could dissect the trials and complain about the quality of medical therapy in the control arms or the sham arms. I mean, these are difficult trials to do. And I think the data set is as good as it can be, given all the limitations. There's also been a steady evolution of the approach over time that it makes it a sort of a moving target, because renal denervation in Simplicity 3 is not renal denervation in some of the modern RECORE trials or even in spiral off-med hypertension. So I think that with the best available technologies, ultrasound-based, radiofrequency-based, it seems like your mean reduction against sham is somewhere in the range of 4 to 5 millimeters of mercury early on, maybe a little longer, say as much as 8 to 10 millimeters of mercury at 6 months or a year. That's a modest benefit on top of standard therapy. To me, not enough to recommend it as a routine strategy for management of hypertension, or as a sort of a baseline against which to titrate other meds. but maybe an opportunity for those who are somewhat resistant to the effects of other therapy, maybe an opportunity for those who have a lot of sympathetic activation driving their blood pressure, and maybe an opportunity for those who just refuse or cannot engage with medical therapy in a reliable manner. There's the similar opportunity, I think, for some of these subcutaneously targeted RNA-targeted therapies, which is prolonged duration of action, tonic control of blood pressure in the background. I think one of the other just general comments, though, is that I think one of the great outcomes of the renal denervation trials has been the understanding that what we think of as resistant hypertension ain't all that resistant, right? For the most part, if you systematically treat blood pressure, even in a population that seems to be resistant, that we can often overcome resistance. And the screen fail rate in those trials was huge. So it was largely because once you subjected those patients to an intensive blood pressure management strategy, you could control blood pressure in many cases. So I think we've learned a lot from those trials. Exactly which patients are going to benefit the most, I think, is a question. And I think we're going to need more experience. Thanks so much.